It's the second effort of the GSA in OTC medication. Some of you may be aware of an earlier effort we had where we looked at OTC behaviors and its relevance and their relevance for old age. This session is very important. We're very pleased to present results from a national summit we held, and I'll describe that in a minute. First, let me do one or two bits of housekeeping. We have a live tweet arrangement going on with this webinar. It's the hashtag OTC Sleep. Kelsey Hines will be presenting some tweets as we go. So if you'd like to participate in that, please go ahead. I just want to give 1 minute of background. We learned along the way of the great need for research on sleep health and OTC sleep aids. You may know that sleep health is an issue across the lifespan with its own challenges in older ages. And we know very little about OTC sleep aids. And so we thought it would be very helpful to bring these together. We also had an inkling and some evidence for many missed opportunities to promote safe and effective use of OTC medications at older ages. So let me begin. We'll go to the next slide now, and let me just describe our panelists. I myself am Steve Albert. I'm at the University of Pittsburgh in the School of Public Health. My expertise is gerontology and public health. We'll be joined by 3 of the 4 other panelists today who were on the OTC sleep aids panel. That's Dr. Phyllis Z from Northwestern, who will bring the perspective of neurology and sleep medicine. We have Dr. Thomas Roth, who will bring the perspective of pharmacology. He's based at the Henry Ford Health System in the Sleep Disorders and Research Center. And last, we have Michael Toscani, who will give the perspective of pharmacy. And he's the fellowship administrator in the Pharmaceutical Industry Fellowship Program at Rutgers at the Ernest Mario School of Pharmacy. Next slide. We'll begin now just so I've introduced the panel. We want to see a little bit about you. There's a quick poll for the audience to complete. I think it's just 1 or 2 questions. If you could go ahead and complete that now, this will give us the profile of who's on the line, which we will share with everyone. Take a minute to do that. With the wonders of technology, we can see that over 75% of you have voted so far. We're up to about 80% voting now, 85%. And we have about 32 registered right now, but I see more people are joining as we go. Please go ahead and vote if you haven't. Okay, we'll take a look at the poll now. Oh, okay, we have, I can give the distribution. 42% of you are from university, 8% from industry, 46% from government, about 12% from medical practices, and 8% other. And that's with 90% voting. I think that's a very nice representation of who's on the line. You'll all have a chance at the end of the 45 minutes or so of presentations to ask questions, and I hope you'll take advantage of that. Okay, so we're very excited. Let's go right into the webinar agenda. I've already mentioned some of the topics we'll be covering. We'll begin with Dr. Z, who will talk about aging and sleep disturbance. Dr. Roth will then talk about the current state of OTC therapeutics for sleep disturbance. Dr. Toscani will then talk about the pharmacist's perspective on gaps in therapies and clinical practice. Let me remind you as well that all the slides you see will be available for download after the end of the webinar. And also everything that we do today will be archived and available on the GSA website, along with some very, very useful background materials on OTC medication, sleep health, and other related topics. We'll go on to the next slide. I just want to give you a minute of background now about the National Summit that we held here in Washington. That was back in October at one of the hotels here. Our meeting was sponsored by Pfizer as part of a collaboration with the Gerontological Society of America. And one other panelist not available with us today is Dr. Michael Vitiello from the University of Washington, who is another key player in our group. If you look at the next slide, you'll see that this was a full-day conference where we tried to raise an understanding of some of the issues related to OTC sleep aid use in older adults and set a research agenda. It was a very ambitious day. We were exhausted at the end of it, but many, many, many good ideas came out of the summit. And this is, as we see it, the beginning of a long process to help define an agenda of research and also practical efforts to improve the situation of sleep health and OTC medications for older adults. Go to the next slide. Some of the issues we raised and some of the objectives of the summit are shown here. I think I won't linger on these because you're going to hear more today from our speakers, but let me go to the next slide and just show you the process as we envision it. We held our summit in October. We've produced a white paper which is available on the GSA website describing the state of the field of sleep health and appropriate use of OTC sleep aids. We've prepared a press briefing and held a press conference at the Gerontological November. And today we're taking it one more step forward for our webinar on sleep health and appropriate use of OTC sleep aids. And last, to be continued, we will carry the story where we will have a symposium describing the results of the effort and also inviting a response from the community of gerontologic researchers. So at this point now, I'm going to step aside and turn the phone over to Dr. Z. She'll talk about the background on aging and sleep disturbance. Dr. Z?
Excellent. Thank you so much, and welcome to this webinar. I want to just briefly give you an overview on some of the causes and consequences of sleep disorders and poor sleep quality in older adults. Next slide, please. Next slide. Next slide. Slide.
One moment, I'm sorry.
I think we have some animations. We will be updating the slide in a sec.
Okay. Sorry.
Do you see your flow chart now, Dr. Z?
No.
We see.
Well, in the next slide, it shows the kind of importance and integration of sleep and circadian rhythms and its important role in both mental and physical health. As there's really tremendous advances in our understanding of the importance of sleep and in particular sleep loss on some of the adverse consequences for health. Sleep is important for appetite regulation, it's important for inflammation, metabolism, and really the function of most of our, really all our systems. And thus, sleep deficiency or sleep loss can certainly have adverse effects on health, on obesity, diabetes, and it really exists for all of these disorders, many of the common disorders that affect older adults. In addition, as one gets older, sleep disorders become more prevalent, including insomnia, sleep apnea, stress, narcolepsy, all that can rob one of sleep. Now, aging itself can affect the circadian and sleep regulation systems, as well as lower levels of physical activity. And So we'll learn in a little bit has the important consequences for safety, productivity, performance, and really of things that have quality of life. Next slide. I'm sorry, I'm not seeing, I'm just seeing changes here.
We have shown your slide now. Sleep disturbances increase with age, insomnia prevalence.
It's not showing on mine here at all. So, okay. The disturbances is not a surprise that with all these age-related changes, the sleep disturbances increase with age. And also, specifically here showing insomnia prevalence. As you can see, nearly 25%, a quarter of older adults have insomnia, and perhaps up to about 60% of older adults have some type of sleep disturbance. Next slide. It's really interesting with older adults when you compare it to, for example, younger adults, is that the types of sleep problems that they report, largely many of them report difficulty really affect the quality of life of older individuals. Next slide. Next slide.
We now have the slide duration of insomnia in the National Comorbidity Survey replication.
Yes, so the next slide is to point out that insomnia is actually a chronic problem. As you can see, if you look at duration of insomnia in this study, you can see that really more than a quarter of those with insomnia that it persists up to 49 to 50 weeks. And then, of course, there are those who, and on the other spectrum, those who have more transient insomnia that lasts maybe just 1 to 2 weeks, where perhaps different kinds of medications may be appropriate under these different circumstances, chronic versus short-term or very intermittent insomnia. Next slide. Not only does insomnia affect, of course, the quality of life of those suffering, the older adults suffering from insomnia, but if you look at this among caregivers of older individuals, particularly those with dementia, you can see that anywhere from 25 to nearly 70%, depending on the study, that the caregivers of those individuals with dementia and or insomnia are greatly affected by sleep disturbance as well. And as we all know, this is very important because those are the caregivers, and if they're not feeling well, if they are ill, they will not be able to provide the caregiving that is necessary. Next slide. What are some of the possible underlying causes? Well, there are multiple. We talked a little bit about alterations in sleep, regulation, and circadian rhythms with age. Sleep becomes more fragmented. You get a little less deep sleep. But also the rhythm changes. So that most older individuals tend to wake up earlier and go to bed earlier. As you'll see subsequently, the majority of problems with sleep are related to the comorbid medical and psychiatric conditions, in addition to some of the late life stressors and psychological factors, such as death, of course, of a spouse or of other family members. Next slide. Here, this study shows that if you look at insomnia prevalence and or any chronic complaint about sleep in older adults, very clear in the green that the healthiest of older people, those in the yellow, have much less difficulty with sleep than that of the general older population, speaking to the fact that most of the sleep disturbance that we see in older adults are likely related or at least associated with comorbid medical and psychiatric conditions. Next slide. Therefore, normal age-associated changes in sleep do occur, but are not primarily responsible for the increased prevalence of sleep disorders, insomnia, and poor sleep quality in older adults. Although they can be, it certainly can be a contributing factor, but the highest contribution is poor physical and mental health. Next slide. The consequences of poor sleep are really, it's a myriad, including difficulty with performance, attention, decreased ability to accomplish daily tasks. Very important for older adults, the memory and concentration impairments. And there's some data to suggest that this is a risk factor, having poor sleep. Cardiometabolic disease may increase in those with poor sleep, shorter survival. There's this really interesting relation between pain and sleep. If you don't get enough sleep, pain threshold decreases. And very importantly, in the older adult population is the increased risk of falls that being associated with insomnia and poor sleep, and not just with medications that you use to treat sleep. Next slide. This next slide speaks to some data on cognitive decline. So if you look at those individuals who have insomnia, either incident or chronic insomnia, you follow them, it's very clear that those individuals with insomnia had a higher likelihood, whether it was associated with depression or not, a higher likelihood, higher odds ratio of developing cognitive decline over time, implying that insomnia itself and poor sleep may be a risk factor for cognitive decline in older age. Next slide. We already spoke a little bit about the impact of insomnia, but I think this is a very beautiful visual way of looking at it. So if you're closer to the center in all of these domains of mental health, physical functioning, bodily pain, general health, vitality, hugely important. It's closer to the center. That means it implies it's poor vitality, kind of a negative effect. And you can see that those with even mild insomnia, and certainly those with severe insomnia, have a very important and dramatic negative impact on their quality of life in all of these very, very important domains. Next slide. Now, as our, in older adults, as now in older adults are employed. And this is important because if you look not only at the effect on their quality of life, if you look at the days out of role when they're actually working, and compare insomnia with all of these very chronic common disorders, cardiovascular disorders, respiratory disorders, pain conditions, insomnia, especially in older adults, if you look at the top line, is an important contributor, perhaps the highest contributor for days out of role in those who are working. Next slide. Despite what we just talked about, the importance of sleep for health, mental and physical health, and all the potential consequences and associations and negatively on health of poor sleep, it is really surprising that it is still a very under-recognized issue in medical practice. This is a study that we conducted in primary care. And you can see that nearly 30%, basically if you add all this up, about 60% of older adults have at least one or more sleep complaints that are chronic. And daytime sleepiness is probably very common. Snoring and difficulty sleeping are the most common. And yet, when we looked at their medical records, what physicians recorded as a problem, as a medical problem, only 20% of the time, even in those who had 5 sleep chronic complaints, was it ever even indicated or indicated in the medical records. So we're not really recognizing this, and I think this is a very important point here for those of us who are taking care of these patients. Next slide. So I just want to summarize by saying that what we know is that sleep patterns do change with age, but it is the change in the ability to sleep in the comorbid medical and psychiatric disorders that are mainly responsible for the high prevalence of sleep problems in older adults. And sleep is imperative for life, for biological function, and similar to nutrition and physical activity, it is really an essential part of prevention as well as perhaps treatment, and really integral part of a healthy lifestyle really for all. And very importantly, in research now is showing that better sleep, improving sleep, can be potentially modifiable risk factor for age-associated impairments in both mental and physical function. So we're really at this point looking at sleep very much at the tip of the iceberg and its relationships to health in general. Thank you.
Okay, thank you. Thank you, Dr. Z. Let me remind everybody that if you have a question, you don't have to wait till the end of the webinar. Please send them in. And if you're inspired to ask now, it's better for us to see now so we can queue up the questions for later. At this point, I'd like to switch our focus to Dr. Roth, who will talk about the current state of OTC therapeutics for sleep disturbance. Dr. Roth? We may have one problem. Hold on, we're going to check on muting of the phones. Apologize for the technical issue. Yes, we're just going to unmute the phone now so we can hear Dr. Roth. I apologize again. Bear with us.
Hello, can you hear me?
Is this Dr. Roth?
This is me.
Yes, please, go ahead. Sorry, we had a little problem with the muting. I just introduced you. You're going to speak about the current state of OTC therapeutics for sleep disturbance, and we'll go on to the next slide right now.
Great, thank you. So I'm going to talk a little about, as you heard from Dr. Z, the prevalence of sleep disturbances in the elderly is very, very high. And one of the things that there are several things which are important to distinguish, and one of those is distinction between insomnia, which is a disorder of hyperarousal, which occurs, as Dr. Z pointed out, about 20% of elderly, as opposed to sleep disturbance, which is a more general thing, and it just to disturb sleep. And that, the prevalence of that is maybe 80–90% of the elderly people. It's very common at some point, not daily, and we can talk about the differences. Insomnia is a disorder. Sleep disturbance is a normal physiological response to a variety of conditions, stressors, things like that. Now, to treat those things, to treat sleep disturbances and insomnia, we have 4 approaches. The top 2 have prescription sleep medications and OTC drugs. And the reason I put those 2 separately is because those, you should know, are drugs which have been studied, systematically evaluated under the auspices of the Food and Drug Administration of the United States and have been judged to be safe and effective, and I'll talk about their indications in a minute. And we know their safety and efficacy, and we know what to expect. In contrast, herbal supplements, we cannot say, and this is I take this from the FDA webpage, cannot say anything about treating medical conditions because these supplements have not been subject to clinical trials and or manufacturing standards. And what's very, very important, finally, as a treatment, especially for sleep disturbance, and again, one of the main conditions in the elderly is a consciousness of economic burdens, and alcohol is very, very commonly used by the elderly, by young people, to improve sleep. It is very important to understand that alcohol has only detrimental effects on sleep. It disturbs sleep in the second half of the night. You heard from Dr. Z that the prevalence of sleep apnea is much more common in the elderly, and as is snoring. You give a snorer alcohol, you get apnea. You give an apneic alcohol, you get more severe apnea because it differentially relaxes the muscles of the upper airway. So it's very important to understand there are 4 different therapeutic approaches. Next slide, please. Now, I'm primarily going to talk today about prescription. I'm going to talk about OTC sleep agents because we're talking about sleep disturbance. Now, prescription sleep agents, prescription hypnotics, are used to treat insomnia. And again, insomnia, but DSM-5 is a disorder of hyperarousal. And there's no limitation on the duration of use. It's a chronic disease, and as such, there's no limitation on how long the medication should be used. And the medications typically are studied to be approved on a chronic basis, studies ranging from 3 months to 12 months. OTC, over-the-counter sleep agents, are not indicated for insomnia, but generally indicated for occasional sleeplessness, typically 2 to 3 days, although that may vary as medications get evaluated. But again, very importantly, these are both medications which are approved by regulatory bodies throughout the world. Okay, now, are these medications differentially used? And this slide is a study from a population-based study in our laboratory, and you can see that just as is indicated by the regulatory bodies, these are the way the medications are used. If you look at less than 1 week, 70% of all use of OTC agents in this population is in fact for less than a week. In contrast, if you look at prescription medications, which is in the purple, they are more typically used on a chronic basis. So just as is indicated in the labeling, whether that's in a package for an OTC agent or in a package label prescription drugs, OTC agents tend to be used on a more acute basis, while prescription medications tend to be used on a chronic basis. However, can I have the next slide? What's very, very important to understand, next slide, if we look at the elderly who happen to have much more continuous or much more chronic sleep disturbances, it's not only more prevalent, but also they're more chronic, you can see that their pattern of use is much, much different. So if you look at the number of days an over-the-counter sleep agent was used in the United States by an elderly population, what you can see is as you go from 60 to 75, roughly a third of the people used roughly a third of the people, slightly more than a third of the people, used the medications at least 20 times during the past 30 days. So that they're not taking them once or twice a week, as we saw in the general population, or once or twice a month, but rather they're taking it 60% of nights. And that must give us some pause. Remember we sort of saw before 75% take less than a couple of days a month. Here we see that number is only about 10%. So the majority of elderly populations are using these medications, over-the-counter sleep agents, for much longer periods of time. And we sort of have to understand and try to understand what are the implications of that and how to educate them about if they really have a chronic sleep disturbance, where it's 20, 30 nights a week, get medically evaluated, take a medication which may or may not be more appropriate. Next slide, please. Now, what are the over-the-counter sleep agents? Well, there really are only two which have been approved in the United States, doxylamine and diphenhydramine. And you'll see in these next two slides, they're very similar. The brand names for these drugs, many of you have seen, are Unisom, Equaline Sleep Aid, Good Sense Sleep, etc. There are many of them. But the most important thing, the two most important things is there are relatively weak H1 antagonists. While we think of these medications as antihistamines, their H1 activity and their anticholinergic M1 activity are about the same. The ratios are mild to moderate. Very important, in the case of doxylamine, it really was approved through the monograph, and there really are no published placebo control on these medications. Now, there may be some studies from long time ago which have not been published, but certainly we're not privy to looking at that data. It's not available to us. Now, let's turn to the more commonly used medication. Next slide, please. Diphenhydramine, Benadryl, and everybody knows this. This is in virtually every sleep, Nidol, Sominex, Tylenol, and all the combinations, Tylenol PM, Excedrin PM, Advil PM. So this drug is used. The most common one today is Sequel. So one of the things that's very important, this is a very commonly used medication. It's also very important to use that besides being used for insomnia, these are drugs which are used for allergy during the day. So it's very important to understand that many times you read things about diphenhydramine, you have to understand whether you're looking at it as a sleep agent or as a medication for allergy or medication for rash. So they're very, very different. But very much like doxylamine, it's a very weak H1 antagonist. The ratio of its antihistaminic activity to its anticholinergic activity are very, very, very similar. But unlike doxylamine, there are several published studies. There's several studies, at least a half a dozen studies. There's only one study, however, in the elderly. It's a crossover study done in the elderly with insomnia. And it's a very, very old study, literally 40, 50 years ago. It's a subjective study, not an objective study. And basically, it decreased awakenings by 1 awakening per night per subject. But it's very important that about the very, very high rate of side effects. And remember we talked about the fact that these are anticholinergic. The most common side effect is dry mouth, dizziness. Those seem to be much more anticholinergic than antihistaminic. So most of the side effects of these medications are in fact anticholinergic, not antihistaminic. And it's very important to understand that that's one of the concerns about the use of this medication. Next slide. You can see this concern very clearly expressed here because you can see that the ratio. So what we see here is the binding affinity of H1 to M1. So on the left side, we see the binding to histamine, and then we see M1 binding to anticholinergic, alpha-1 adrenergic, norepinephrine. But you can see that the ratio of antihistaminic activity to antimuscarinic activity is almost exactly the same. And in fact, if you look at many pharmacology textbooks, these are called anticholinergics rather than antihistamines. There are other medications. Which at some point we can talk about, which are actually approved for sleep as well as approved for depression, which are much, much more antihistaminic versus anticholinergic. So there are drugs with a much better H1 to M1 ratio in the medical literature. Now this M1 issue is a big concern. Next slide. As many of you know, next slide please. There's a Beers list, and this is and the Beers list is basically medications which are some concern for use in the elderly. These are appropriate, and these are very specifically, they're talking about highly anticholinergic medications that will reduce clearance with the advanced age, and we'll talk about that. And the use of diphenhydramine in special situations such as acute treatment for severe allergic may be appropriate, but generally the use of diphenhydramine doxylamine, according to the Beers criteria, should not be used, and again, mostly because of their anticholinergic activity. So again, this is a Beers list of medications criteria for potentially inappropriate medication for use in older adults. So this is something to consider. And again, this is medications which are seen to be very anticholinergic, not necessarily antihistaminics. In fact, if you look at the far left, the list of medications is anticholinergics. Next slide. Now, the other concern about the use of these medications, diphenhydramine, is their half-life. I'm going to show you one sample of a study which showed residual effects, but there are an equal number of studies which do not show residual effects. The half-life changes with age, and that's a big issue. This is a study by Zhang, and it sort of looks at a PET scan, and in the middle you can see, an FDG PET when people are taking placebo, and then on the far left you can see diphenhydramine, and you can see the sedative activity. This was done at 9 o'clock in the morning after taking a dose at night. And this is Journal of Clinical Psychopharmacology in the last several years. And you can see there's pharmacological activity, at least in terms of binding to receptors in the brain, roughly 9 to 10 hours after taking the medication. Next slide. Now, one of the reasons that this is on Beer's list is because this is a special problem in the elderly. So what we have here is nanograms per mil, or serum concentrations. The first line, which has a very steep slope, is children with a mean age of 9. Then the middle line is middle-aged people, middle age of 31. And the top line is mean age of 69, which is not that old today. And what you can see is as we get older and older, there's a significantly longer duration of action. So if you look at that slide and you look at 30, 40 hours after you take the medication, you still have significant blood levels of diphenhydramine in the elderly population. So we have to be very concerned, one, about cholinergic activity, two, about residual effects the next day. There's very good data when it's used immediately after taking it in terms of driving behavior, that there's driving impairment. That's when it's used as an antihistamine during the day. Generally, when you're taking it as a hypnotic, you're going to sleep through the first 48 hours of that activity. Next slide. And this sort of shows, next slide, this is the results of a clinical study. Most recent one, this is published this was a study by looking at temazepam, which is a prescription sleep medication, and diphenhydramine versus placebo. And you can see that diphenhydramine shows significant impairment in many of the cognitive functions that Dr. Z talked about. So it's very important to understand that if we have sleep disturbance, one of the things we want to do, not necessarily simply sleep better, but to decrease the cognitive impairment. And in fact, here, if you look at things like digit span, cancellation tasks, vocabulary, they get impaired the next morning. These are always the next day. And the final slide, next slide. So I'd like to leave you with the idea that it's very important to understand the indications for over-the-counter sleep agents. It is not for insomnia, but rather occasional sleep disturbances. They should be used not on a regular basis. And we have to have some concerns in terms of the currently available medications. They have to be monitored. One, because there's an increased half-life with age, so you get a lot of residual effects. Two, there are the muscarinic side effects, the anticholinergic side effects. And three, the efficacy data at this point in time is not overwhelming. Thank you very much for your attention, and I'll turn it over now.
Thank you, Dr. Roth. Remember, anyone who wants to send a question in, please go ahead. I'm going to turn the microphone over now to Dr. Michael Toscani, who will give us the pharmacist's perspective on OTC sleep aids. Dr. Toscani?
Thank you very much, Dr. Albert, and thanks to my other presenters, Dr. Z and Dr. Roth, and thanks also to the Gerontology Society for putting on this summit. My presentation today, we're going to focus predominantly on the OTC use from the pharmacist perspective, looking at potential gaps in areas where pharmacists can help influence the better care of patients with sleep disturbances. As you've seen from previous slides, sleep disturbances in the elderly particularly are problematic, and pharmacists offer a wonderful opportunity to engage those individuals because of the ease of access of care that they have. The elderly pose a particular challenge for folks because they have other comorbid conditions and certainly are taking many, many more medications than the average 20 or 30-year-old. As you can see from the next slide here, the pharmaceutical care is really involved with providing advice and direction and education to those individuals and professional consultation. And the same is true when folks come and talk about sleep issues. As Dr. Z pointed out, that's one of the gaps in that health professionals in general don't ask enough questions about sleep, and even if they ask questions about sleep, they don't necessarily document that information regarding sleep. So the pharmacists have a very good opportunity not only to engage patients in the community setting regarding sleep, but also have the medical records there in their pharmacy that can look and see what other products the particular patient is taking. We're going to review on the next slide a little bit of some survey findings of how pharmacists get involved with some of their recommendations. In general, pharmacists make on average about 30 recommendations and counsel folks for an average of about 5 minutes per consultation. What's also interesting is that almost 80% of individuals end up taking advice and purchasing those agents that are recommended. And after counseling those individuals, the pharmacist is in a very good opportunity for making referrals, and many of them do. 73% of the time make referrals to healthcare professionals regarding some follow-ups with particular patients. If we go to the next slide, we know from what we've heard before that there's quite a number of folks, particularly elderly, that have issues with not only insomnia, but particularly those who have short-term sleep disturbances. And as you can see, 44% of older adults experience sleep disturbances at least a few nights each week from the National Sleep Foundation. 23% report taking sleep medications in the last month, and 15-18% use over-the-counter sleep medications. One important point I want to mention about this is 40% are currently taking one or more anticholinergic medication. And as you heard from Dr. Roth, a lot of the over-the-counter medications that are used have quite a bit of anticholinergic activity. And when combined with other agents that the patient may be taking that have anticholinergic activity, you really have, in some cases, a very high anticholinergic burden, which for the elderly poses a particular problem, which we'll talk about clinically in just a second. If we go to the next slide, we'll talk a little bit about, this is a survey that was done by the American Pharmacists Association. Over the course of a week, the number of individuals that they make recommendations for. No surprises, as Dr. Roth mentioned, diphenhydramine and doxylamine. Now, what's important to recognize about this slide is that this is recommendations for single ingredient products. We know that most individuals, especially the elderly, take products containing these agents along with other things like Tylenol, PM, other pain medications which coexist with these products for sleep, particularly in the elderly. So the next slide, we'll talk a little bit about some of the things that pharmacists should be certainly with in discussing sleep with patients, particularly as these are some of the assessments. And it takes a very short period of time to do this. How many hours of sleep do you get on average? Do you have problems falling asleep, staying asleep? How often does that occur? What they feel like during the day. Do they feel sleepy and drowsy throughout the day? And what type of agents are they taking with sleep? Not only over-the-counter medications, but Dr. Roth mentioned some patients may be taking not only herbal medications, but they may also be using alcohol for sleep as well. And we know that alcohol really has only detrimental effects, and more detrimental effects when combined with some of the over-the-counter sleep aids. So we can go to the next slide. Some of the questions that health professionals, and particularly pharmacists, certainly should be talking about to older adults regarding their sleep is the issue between, is it occasional sleepiness over 1 or 2 days, or is this really a chronic problem? And just as we emphasized before, the over-the-counter agents are not labeled for chronic insomnia. They're really labeled for short-term sleepless issues. We know that most recommendations are right now for diphenhydramine and doxylamine containing agents, and we know that those agents for the elderly on the Beers criteria are ones that we have to be very, very careful, if not completely avoid, particularly in individuals in the elderly that have coexisting conditions like BPH, glaucoma. If they're taking other anticholinergic medications, if they're taking. And we also must look at the pharmacokinetic and pharmacodynamic situations. Are we considering whether or not this drug, if used chronically in these individuals, could accumulate, or perhaps if it's used acutely, is it going to cause them some daytime sleepiness? in this particular population of individuals, certainly in the community or if they're in long-term care or in assisted living facilities, what effects is that going to have on them in terms of their sensorium, their risk of falls, whether they can drive, and so on. So these are all items that really need to be addressed when discussing sleep aids in the older population. Next slide, please. We know that pharmacists, through providing good pharmaceutical care, are trying to certainly become more well-informed. We know there is an educational gap. I think more training and education needs to be done in order to help drive better outcomes in these individuals. And I think through better discussions with both health professionals and with patients, pharmacists offer a wonderful opportunity to help improve the care of patients and the elderly, particularly when it comes to making recommendations regarding sleep aids. And we know that that has a huge improvement or potential improvement for not only their sleep, but also their quality of life, which, as we heard from Dr. Z, very much related to how well one sleeps. I think that is the end of my presentation. I believe I'll turn it back over to Dr. Albert.
Okay, thank you, Dr. Toscani. So we've heard from our three presenters. We're going to open the floor now to questions. So please feel free to write in. You can see the facility, the chat room facility, to send any questions in. But let me begin by throwing a question out to our panel, and all three should feel free to respond. What do we do when we find an older person managing insomnia with an OTC product? What should be the appropriate counseling for that person? Dr. Z, do you want to take that to begin? Or perhaps Dr. Roth or Dr. Toscani?
I'll give it a shot. This is Tom. This is Dr. Roth, Tom Roth. I think there are a couple of things, that you heard in the presentation. One, we want to find out if this is an occasional sleep problem, because that's what these medications are best suited for. Or is this just some, this is a chronic problem? Do they have this 7 nights a week? Do they have this for the last year? The other thing we want to find out, which is very, very important, is there a cause which is identifiable? Is there something wrong with their sleep environment, what we refer to as the circumstances to sleep? If in fact you just have occasional sleeplessness, and then I think we can sort of monitor them, we can encourage, we can affirm the use of these over-the-counter sleep medications. But we then have to monitor them. One, are they taking the right dose? Two, very importantly, are they cautious the next day by driving for the first few hours? Or do they know how well they function? Are they having difficulty with sway? So again, I think we want to do two things. One, I think first of all, we want to find out whether an appropriate patient from the point of view of they're not taking too many anticholinergic drugs, they don't have chronic insomnia. And two, we want to monitor their progress on taking the medication in terms of potential anticholinergic and residual side effects.
Okay, very good. Thank you, Dr. Roth. Dr. Toscani, do you want to add something?
The only thing I would add to what Dr. Roth mentioned, all those are very important. I would also look at or ask the individual what other medications they're using, particularly looking at whether they have, if they're elderly, if they're taking other anticholinergic agents that may add to their burden. And also, if there is an issue with insomnia, then it may be more appropriate to start making some recommendations for some further follow-up of care and taking a look at making the proper diagnosis for that and the proper treatment, perhaps with prescription agents. I asked them about their sleep hygiene as well, and perhaps there's some non-pharmacologic things that they could be doing that may help with their sleep as well.
Very good. That bears on a few questions we've just received. When you say non-pharmacologic strategies, can you go into any detail? Dr. Toscani?
I know there's some cognitive things that can be done with patients. I think Dr. Roth and Dr. Z are better at probably describing that type of therapy, but certainly good sleep hygiene. I think making sure the room is is dark, making sure that there's no other things that are cell phones and computers and lights and other things that may disrupt that. But those are some of the things that I think some folks tend to overlook, and they're not necessarily sleeping in a good environment. that's conducive to good sleep habits. I don't know if Dr. Roth wanted to add anything more about the cognitive types of therapy.
Well, yeah, so certainly everybody should have good sleep hygiene practices, and you can get a list of those anywhere. Now, beyond that, there's cognitive behavioral therapy, and cognitive behavioral therapy primarily is an attempt, there's other things, but primarily an attempt to increase homeostatic drive. And it does that through like sleep restriction. That is, many people, like elderly people, will spend 8-9 hours in bed, so they'll distribute their sleep over those 9 hours. So you sleep restrict them. You limit, very simply, just limit their time in bed. If you sleep 6 hours and you're 6 hours in bed, you feel much better than if you sleep 6 hours spending 9 hours in bed, because it gets distributed. And their stimulus control does the same thing. They're very, very effective treatments. In the elderly, we have to have some pause, because the major side effect of this is because you're increasing homeostatic drive, you get sleepy during the day, which is not an uncommon problem in the elderly. So again, behavioral therapies are very effective. They've been shown to be effective in the elderly specifically, but again, it should be done with some kind of monitoring, especially for sedation the next day.
Yeah,
Very good.
In addition to that, this is Dr. Z, I would add that getting regular exercise, having structured physical and social activities in older adults has been shown to also improve sleep quality. And in addition to that, in addition to not getting, having a dark environment to sleep, it's equally important, especially in older adults, to be exposed to bright light during the day, particularly in the morning and in the afternoon. I mean, those are very powerful, I think, environmental stimuli for better sleep.
Yeah, I think that's incredibly important. There's one study which sort of showed that elderly people pretty much live in the same illumination 24 hours a day. Because they keep lights off during the day to save money, but then they keep lights on at night because they go to the bathroom and they don't want to fall. So I think I just want to just reinforce what Dr. Z said: bright lights during the day, especially in the morning, in darkness at night. If you're going to go to the bathroom, the light should be near the bathroom, away from the gaze, the eyes, when you're sleeping at night. I just think that's an incredibly important point in elderly populations.
Very good. We've had a few more questions here. While the focus of our webinar was not herbals or melatonin or aromatherapy, people are asking about alternatives to OTC products to manage sleep problems. Have there been head-to-head comparisons, or does the panel have thoughts about these alternatives?
I'll defer on melatonin to Dr. Z, because she certainly, has done a lot of work in that whole area of circadian rhythms. If you look at the other herbal medications, the only one that's been studied systematically is valerian root, and there's a double-blind study by Dr. Moran, which is published actually in JAMA, and it has no effect at all. And one other point, which I think is just incredibly important to understand, is other than the fact, besides the fact that these medications, when they have been studied, and valerian's root is one that has been studied, and it's not effective, because they're quote-unquote health food stores, does not mean they are safe products. Their safety is unknown. Kava, which is a health food product, has been shown to have effects on liver function. So again, I would not use these medications. So although you could go to a health food store and buy them, I would not use these medications without consulting with your physician first. But I can say without any question, there are no data to show that any of these work in any way at all. And in the case of valerian root, it's been shown not to work. And again, I think Dr. Z can answer the issue regarding melatonin.
Yes, thanks, Tom. With regards to melatonin, as a hypnotic medication for the treatment of insomnia, it's at best, there's really no data to support its efficacy as a treatment, as a hypnotic for the treatment of insomnia, and at best, some of the results are inconsistent. However, in Europe, there's a kind of a prolonged release melatonin formulation that has been studied in clinical trials in older adults who are 55 years and older, and was shown to be, it's a small study, but still shown to be effective in the treatment of primarily both primary sleep maintenance in older adults. So there is some data, but not the usual typical nutritional supplement that you can get in a health food store or at the supermarket. So, however, if you have a circadian problem, such as if you are waking up too early or you can't fall asleep because your clock is misaligned, melatonin has been found to be effective in some of these populations with circadian rhythm disorders. But the majority of patients, older adults with sleep problems, insomnia, probably do not necessarily have this type of circadian problem. So again, the data is very limited in that area. There are no really even double-blind multi-center trials necessarily for that. There's a trial that was conducted years ago in individuals with Alzheimer's disease for their sleep was really a negative result. That was the only multi-center trial on melatonin.
Dr. Albert,
thank you. We've had
Dr. Toscano.
Oh, go ahead, please. Go ahead.
Yeah, thank you. I just wanted to add regarding the supplements is that very little is known about sometimes the drug-to-drug interactions that those agents may cause. Because they're not very well studied, sometimes it's difficult to ascertain whether they will cause either drug accumulation or an increased drug elimination in some cases. So there are some supplements that can change the metabolism of drugs, and so those again may not be well studied and could cause some difficulty with some patients who are taking some of these agents concurrently.
Very good. Let me throw out one last question. I think we're going to have to wrap up soon. And this was a question about some of the moderators of the anticholinergic effects of OTC products. Does it matter if someone is male or female or has a neurologic disease or not, or of a different race or ethnicity? Has there been any research on people's differential susceptibility to the anticholinergic effects? Dr. Roth,
I think Tom,
want to weigh in on that?
Yeah, Dr. Roth. This is Dr. Z. I would only add that especially in older adults with cognitive impairment, the anticholinergic effects can have really substantial negative effect on cognition in those who are already impaired, because of course the cholinergic systems are important for that and also for alertness. So I think in vulnerable populations that would be a problem. Patients with cardiovascular disease and cardiac disease, the anticholinergic effects can produce cardiac arrhythmias as well.
Very good. Okay, our last question is actually a very good segue to our next slide, so let me move on to that. And I just want to alert you to the many resources available on the GS we've prepared through our collaboration between Pfizer and the Gerontological Society. There's the What's Hot newsletter, which has one issue focused especially on sleep. There's the slide set, which we've shown today. And there are a number of one-page sources of information about sleep health and OTC products, all available for downloading on the website, which has, the URL is available to you there. So let me thank the attendees and let me thank the panelists. Before you hang up, I hope you'll take a minute to look at our webinar evaluation. We would love to get a little feedback from you. If you click on the survey link at the end of the webinar, you'll get a chance to provide some feedback. We take it very seriously. We're always trying to improve our efforts here. So let me thank you again. We hope you enjoyed the program, and we hope to see further activity as we come together to try to think about the best ways to address sleep disturbances in older age and what sorts of over-the-counter products might be most useful and how best to encourage safe and effective use of those products. So thank you very much. Bye now.
Bye-bye. Have a good day.
Bye, everyone.
Bye-bye.